Let's go. Here's a little song I wrote. You might wanna sing it note for note. Don't worry. Feel happy. In every time expect some trouble. When you worry, you make it double. Don't worry. Feel happy. Don't worry, feel happy. Don't worry. Feel happy. Don't worry, feel happy. Don't worry. Feel happy. You got no place to lay your head. Someone came and took your bed. Don't worry. Feel happy. Your landlord say your rent is late. He may have to litigate. Don't worry. Feel happy. Don't worry, feel happy. Don't worry. Feel happy. Don't worry, feel happy. You got no place, you got no cup, you got no girl to make you smile.
Don't worry. Feel happy.
Cause when you worry, your face will frown, and that will bring everybody down. I say,
Don't worry.
Feel happy. Don't worry, feel happy. Don't worry. Just enjoy yourself. Don't worry, feel happy, bro. Don't worry. Feel happy. Inner thoughts. Now so, I didn't hear you. One love, one heart. Let's get together and feel alright. When you hear them crying,
One love.
when you hear them crying,
One
one
heart.
heart. Say,
Let's
let's
get together and be alright.
one love, one heart. Give thanks and praise to the Lord, and I will feel alright. Let's go. One love. One love. Everybody, one love. One heart.
Let's get together and be alright.
Can we please settle down for the procession? Ladies and gentlemen, can we please settle down? No more moving about, please. Please, can we be upstanding as we welcome the procession? Please, let's be upstanding as we welcome the procession. Leading the procession is the Principal Assistant Registrar Admin Unit and the Secretary Senior Ceremonials, Mrs. Basirat Sadiq. Please, let's be upstanding. No movement, please. No movement, please. And clear the aisle. In the procession, we have Dr. Udora Neka, Professor O.A. Okese, Dr. Matthew Eze, Dr. Eze Chico, Dr. Leonard Adra, Dr. Ume Chioma, Dr. Ume Uchenna, Dr. Asawa Osti, Dr. Helen C. Okoye, Professor Henrietta U. Okafor, Professor C. A. Iwe, Ioke, Dr. J. O. C. Onya, Professor O. C. Ene, Professor Bond Anyehe, Professor C. I. Udoye, Professor A. Yukachi, Professor Peter Ezea, Dr. Duru, Dr. Obina R. Okwesili, Dr. Eloka Uchim, Dr. Silva O. C. Weze, Dr. Lilian Okwesili, Venerable Professor C. I. Okafor, Professor Onyekulu Fidelis, Professor Mrs. Ifoma Okoye, Dr. Wafo Michael, Dr. Okon Silas, Dr. Nelson Charles, Professor Uzo Anyebwe, Professor Okechukwu Wankwo, Dr. E. A. Akachi, Professor P. O. Ugwu, Professor Okoli, Professor C. B. Wansu, the former Provost College of Medicine, Professor Uche Nawara, Professor J.C. Eze Oracle, Professor Maduka Uansono, Professor B.C. Wangoma, Dr. C.O. Adiri, Professor Beke Tagbo, Dr. Obiaju Onya, Dr. Ngozi Ardim, Dr. Esther, Dr. Chris Anyerobi, the Deputy Vice Chancellor, University of Nigeria, Enugu Campus, Professor Daniel Wachiku. The national anthem, first stanza only. The University of Nigeria song. terms of learning, the University of Nigeria is all sublime. While we're still standing, please permit me to make welcome to the microphone Venerable Emeritus Professor Ernest Onwasigwe to please come give us the opening prayer.
Let us pray. Our most gracious Father, we thank you for this wonderful day. We thank you, Lord, for this day of gathering, this day of thanksgiving in our hearts. We thank you, gracious Lord, because you have blessed us with joining mercies. Lord, we pray that you descend in your majesty and abide with us. Direct us in all things, gracious Lord, and in the end, Lord God, may we go rejoicing. For we prayed in the name of the Father, and of the Son, and of the Holy Spirit.
Can we please settle down? Council members of the University of Nigeria here present, principal officers here present, distinguished academics, my lord spiritual and temporal, members of the fourth estate of the realm, gentlemen of the press, lions and lionesses, lions and lionesses, ladies and gentlemen, I welcome you all to this very wonderful academic discourse, yet another wonderful academic discourse, the 185th in the series of inaugural lecture. Today, we'll be listening to a topic that says the obstetrician and the female pelvic floor, protecting the floor and improving childbirth experience. But before we go into that, permit me to introduce to you members of the high table. Acting in double capacity is a man who's seated there. He's representing the Vice Chancellor and as well acting in his own right as a Deputy Vice Chancellor in Inaugural campus. Ladies and gentlemen, please put your hands together for Professor Daniel Nwachukwu. I'll go further to introduce past inaugural lecturers here present and those seated in the front of the high table. Permit me to introduce to you the Chairman Senate Ceremonials, Professor Benneth Wanguma. The Provost College of Medicine, who's also a past inaugural lecturer, Professor Hyacinth Ezegui. The Deputy Provost College of Medicine, Professor Kajetan Onyedum, past inaugural lecturer as well. The Dean Faculty of Medical Sciences, Professor Emmanuel Ejim. If your hands are not too busy, please appreciate them. We also have on the high table the Chief Medical Director, University of Nigeria Teaching Hospital, Itukwozela. Sorry, his name is not here. All right, Professor Onodugu. I'll do the introduction better later. We have Venerable Emeritus Professor Ernest Onwasigwe, past inaugural lecturer, former Provost College of Medicine. Professor Uchin Nawa, past inaugural lecturer. Professor Bon Anyehe, past inaugural lecturer, my very own good friend. The Deputy Provost College of Are you sure I've not recognized this before? Sorry. Professor S.O. Ikenze, past inaugural lecturer. Professor Samuel Obi, former HOD Department of OBS, past inaugural lecturer. Please put your hands together for him. Professor Henrietta Okafor, past inaugural lecturer. Professor Obina Onwuchekwe, past inaugural lecturer. Professor Sebastian Ekenze, past inaugural lecturer. Professor Maduka Oasoro, past inaugural lecturer. Permit me to, at this juncture, recognize the 185th inaugural lecturer in our presence, who is yet to deliver his lecture. Ladies and gentlemen, please put your hands together for Professor Emmanuel Onyebuchi Valentine Ugwu. Professor Emmanuel's wife, I would like to recognize her also, Dr. Ogechuku Angela Ugwu, the wife of the inaugural lecturer. Is she here? Permit me to also recognize Professor John C. Eze, past inaugural lecturer. Professor Cyril Dean, past inaugural lecturer. Please put your hands together for them, it's not easy. I'll quickly recognize the family of the inaugural lecturer that are here present. Ladies and gentlemen, please put your hands together for Onyebuchi Valentine Ugwu Jr., the son of the inaugural lecturer. We have Chidumebi Shirley Ugwu, the daughter. Chisom Ugwu, a son. Please appreciate them. Kenenna Casey Ugwu. Onyinye Princess Ifani, cousin. Sir and Lady F.E. Ezenwa Bachili, father-in-law. Please put your hands together for the father-in-law here. Reverend Sister Dr. Chika Ezenwa Bachili, sister-in-law. Please give us a wave. If you hear your name, just give us a wave. God bless you, sister. Welcome. Mr. Kenechuku Ezenwa Bachili, brother-in-law. Please give us a wave. God bless you. And Kiru Ezenwa Bachili, sister-in-law. They all came out in their full regalia to support the inaugural lecturer. Engineer and barrister Mrs. Valentine Ezenwa Bachili, brother-in-law. He's here with his wife and children. Please give them a worthy round of applause. It's not easy. Dr. Uchenna Ogbu, uncle, appreciate him, please. Barrister Ima Asogwa. Dr. Festus Ezema, the brother, please appreciate him. Barrister Johnson Olotu, cousin, please appreciate him. Mr. Odwa Timothy, Peace Ogwama, Honorable Chidi Obeta, please give us a wave and appreciate them, please. It's not easy. Honorable Chidi Obeta is the honorable member of House of Representatives, representing in Suka and Ibwezi South local government area. Honorable, if you're here, give us a wave, please. Can we also please put our hands together for Barrister and Dr. Mrs. Pius Idoko, their family members to the inaugural lecturer. Ugu Nabuike Anthony, Ugu Dorothy, Ugu Nkechi, Ugu Chioma, Ugu Ijoma, and Ugu Chibuzo, sister and brothers to inaugural lecturer. They are his siblings. Please appreciate them very specially. Okay, Professor Bonnie Eze, past inaugural lecturer. I've actually recognized him before. Professor Ifoma Olasi, past inaugural lecturer. Please put your hands together for them. It is not easy. At this juncture, ladies and gentlemen, please permit me to hand the microphone over to the Chairman, Senate Ceremonials, to proceed with this event. After the inaugural lecture, we will continue with recognitions. God bless you. Please put your hands together for Professor B.C. Wanguma.
Thank you so very much, Joyce. Good job as always. Good afternoon, ladies and gentlemen, the chairman, distinguished members of the Senate of the University of Nigeria, principal officers here present, members of the Governing Council, friends and guests of the inaugural lecturer, staff of the University of Nigeria, lions and lionesses. It's my pleasure, as always, to welcome you to yet another inaugural lecture of the University of Nigeria. And on behalf of the Senate Ceremonials Committee, which I chair at the moment, promises to be another pleasant experience. Well, as you already know, the 185th inaugural lecturer is Professor Emmanuel Valentine Ugwu, and his topic is the obstetrician and the female pelvic floor, protecting the floor and improving childbirth experience. And that done, it's my pleasure at this point to invite the Deputy Vice Chancellor Enugu Campus, Professor Daniel Nwachukwu, who is standing in for the Vice Chancellor as the chairman, to jumpstart the inaugural lecture with an opening remark. The chairman, sir.
The Vice Chancellor, University of Nigeria, Professor Charles Arizechukwu Igwe, principal officers of the university here present, members of the Governing Council here present, past inaugural lecturers, distinguished professors, my lords spiritual and temporal, members of the Fourth Estate of the Realm, gentlemen of the press, ladies and gentlemen, lions and lionesses. I, on behalf of the Vice Chancellor, welcome all of you to the 185th inaugural lecture of the University of Nigeria, to be delivered by no other person than Professor Emmanuel Onyebuchi Valentine Ugwu. We all know we are gathered here in our numbers, which is what the college is known for. And I want to appreciate all of you for turning up in mass to give him the moral support. And we all know that what the journey of becoming a professor, he wants to prove to us that he truly merits to earn a professor in University of Nigeria. And we all know the road is not easy, but we trust what our own Professor Valentine Ugwu can do, and we know he's going to deliver. Ladies and gentlemen, let us listen to him and see what the works he has done that will enable us to see how the female pelvic floor can be protected and how childbirth experience can be improved. We will sit back for the next 1 hour and listen to our inaugural lecturer. And be rest assured, he has a lot to offer. We trust what we can do, and we all know him. And be rest assured, you will be happy attending this inaugural lecture. Ladies and gentlemen, I want to appreciate all of you, and on behalf of the Vice Chancellor, I want to say welcome to the 185th inaugural lecture of the University of Nigeria. Thank you, and God bless all of you.
Thank you, Chairman. May I invite most respectfully the Dean of Medical Sciences, Professor Emmanuel, to read a citation and formally present the 185th inaugural lecturer of the University of Nigeria. It's an applause for him, please.
The chairman of the occasion, other protocols observed. This one is a little bit, it's going to be a little bit more difficult because we have too many things in common. Permit me to use the term Brother Val Ugwu. I mean Bro Val and Professor Val interchangeably because to me they mean the same thing. Those who know, know. Professor Emmanuel Onyebuchi Valentine Ugwu was born to late Mr. Augustine Ugwu and late Mrs. Janet Ugwu of Ibagwane in the Soka local government area. He had his primary education at Central School of Balibo and his secondary education at Community Secondary School Ibagwane. Well, when I was going through his resume, I kept on wondering what this bond, holding myself and bond and Val together, where did it start? I was actually born of water and spirits in his village, Opalibo. That was why I had my infant baptism, and the bond, I've now realized why the bond is more spiritual than physical. He was the best graduating student from that community secondary school, Ibagwane. He attended a community school. He obtained his medical and MBBS from University of Nigeria in the year 2001. And remained at UNTH for his housemanship between the years 2002 and 2003. He went to Federal Medical Center, Gombe, and had his youth service. At least he has an original certificate. He's not fake. Thereafter, he quickly commenced his postgraduate training in the Department of Obstetrics and Gynecology at the University of Nigeria Teaching Hospital in the year 2005. And within 4 years, he got his fellowship from the West African College of Surgeons. 2 years later, he also got a fellowship from the National Postgraduate Medical College of Nigeria. So he's a double fellow. During his training as a resident doctor, he was appointed the chief resident of the Department of Obs and Gynae. That office is more like an assistant head of department because he was coordinating the activities of residents as well as that of some students and other non-academic staff. Upon completion of his residency in 2005, he was appointed a lecturer 1 in the University of Nigeria in April 2011. And I remember that appointment very well. Within 4 months, he was appointed an honorary consultant, obstetrician and gynecologist by the University of Nigeria Teaching Hospital. Unlike some of us who stopped reading after our fellowship, myself and the CMD would not be reading in the past so many years. Val went ahead to obtain a master's in public health from the College of Medicine in 2012 and got another master's degree in public administration from the National Open University of Nigeria in 2017. And a year later, he became a fellow of the International College of Surgeons. He didn't stop there. He also obtained a master's in science degree in human reproduction and women health at the Institute of Maternal and Child Health of UNN in 2019 and graduated with a cumulative grade point average of 4.74. That's first class. The type of things we get. In 2022, he obtained his Doctor of Medicine by thesis from the National Postgraduate Medical College of Nigeria, being among the very few that have obtained this degree by thesis. Most other ones are awarded, like I know I'm going to be awarded mine because I don't have the time to write thesis. But he wrote his thesis just like a student and got it. He didn't stop there. He's still pushing degrees. He has completed his Doctor of Philosophy, that's PhD courseworks, seminars, and has presented his finished PhD thesis to the board of the Institute of Maternal and Child Health of UNN, and is awaiting final and external defense, which has been fixed in the next 2 weeks on the 28th of this month. So, on appointment in 2011, as expected, within 3 years, he became a senior lecturer, unlike the former provost. And within another 3 years, he was appointed an associate professor. And another 3 years ago, he became a full professor of the University of Nigeria. So he had a very smooth progression. There was no truncation at any point. Okay. So Val is an examiner and a supervisor. He serves an external examiner to several medical schools, both here in the Southeast and outside the Southeast. He's a faculty member, as well as a postgraduate examiner at the National Postgraduate Medical College of Nigeria, as well as the West African College of Surgeons. He has supervised more than 30 Part 2 postgraduate medical dissertations for both colleges. And some of them had received awards as the best dissertations in postgraduate medical examinations. Brother Val has initiated and completed several research projects and obtained numerous research grants in the fields of maternal and child health, malaria, HIV, pelvic floor disorders, gynecological cancers, infertility, Cochrane systematic reviews, as well as in public health. So it doesn't just depend on his salaries and private practice. He gets a lot of research grants, and that's why he's a big boy. Supervision and mentorship. As a result of all these publications, research work, Val has published more than 150 papers in peer-reviewed journals at this very young age. And over 80 of these are in journals with Thomson-Reuters Impact Factor and Schimago Journal ranking. He has over 80 publications indexed in PubMed and has a Google Scholar citation of 2,268. He has an HI index of 25 and an I index of 47. Val has a research gate score of 32.25, as well as a research interest of 1,033. He has presented more than 70 papers in both local and international conferences. One of his recent publications received an international recognition, honorary mention award, as the best clinical research article in low and middle-income countries from the International Federation of Gynecology and Obstetrics, that's FIGO, in 2015. He also received another award from the Journal of Obstetrics and Gynecology Research Society of the ONG Association of Japan for an article he published in 2018 and as the most cited of all the clinical articles for that year by that journal in Japan. So his article was cited more than that any other person in that journal for that particular year. In 2018, Val was honored with the prestigious University of Nigeria Nsukka Excellence Performance Award in the academic staff category. And a year before then, he was a distinguished recipient of Professor Ugwu Award for Academic Excellence in the College of Medicine at the University of Nigeria. He served as the pioneer editor, or rather the pioneer postgraduate coordinator, as well as deputy editor of the Institute of Maternal and Child Health of the College of Medicine, UNN. He was the former managing editor, stroke deputy editor of the International Journal of Medicine and Health Development, formerly called the Journal of College of Medicine, our own dear journal. He is currently the editor-in-chief of that journal and has done a lot of work to improve the visibility of that journal. And very soon that journal will be in PubMed and even we'll get Impact Factor. That's where we're going. He's the current section editor of the Nigerian Journal of Clinical Practice, the official journal of the Medical and Dental Consultants Association of Nigeria, one of the very few Nigerian medical journals that has Thomson Reuters impact factor. Val is not just a book person. He is also into administration. He is the second in command at the University of Nigeria Teaching Hospital, being the chairman, medical advisory committee, as well as the director, clinical services, research and training of the hospital since May 2019. He has actually overstayed because he has spent more than 4 years. CMD, I hope you are taking notes. This particular role carries significant responsibilities because the crucial role in maintaining the institution's reputation for medical excellence. So if your patient or relation comes to UNTH and is not properly treated, he is responsible. And if he comes and is properly treated, then he should take the accolades. Membership of societies. Val is a fellow of the International College of Surgeons and a prominent member of the Society of Obstetricians and Gynecologists of Nigeria, SOGON. He's also a member of the Nigerian Medical Association, even though he doesn't contest elections there for fear of failing. He's a member of the International Urogynecology Association, as well as a member of the American Urogynecology Society, as well as the South African Cochrane Collaboration. And on a more important note, Val is a Catholic, devoted, and an active member of the Ark of Covenant Presidium, Legion of Mary, at the old UNTH. And for him, it's a difficult thing because our president is a medical student in that association. And when Val comes late to meetings, the student actually punishes him. Sometimes ask him to stand up for the next 30 minutes for coming late. Imagine a student punishing a professor. That's the humility we have in the Legion of Mary. So, well, for his hobbies, he claims he loves gisting, but I know that he loves arguments. Val argues a lot. Those who know him well will know that he argues. I don't know why he didn't put it here, but he loves arguing, he loves arguments, he loves gisting, reading journal articles, and watching football, of course, like most of us. And I think in 2005 or 6, Val came and took away my house officer and insisted that he must marry her. So he's happily married to Dr. Angela Ogechukwu Ugwu ni Ezamwabachile, a senior lecturer and consultant hematologist and current head of department of the Department of Hematology. The marriage is blessed with 4 children. Well, in the last few days, Val sent a letter to the Dean's office, well, a letter to the Vice Chancellor through the Dean's office, that he wanted to establish an endowment fund in honor of his late parents. So as part of his efforts to inspire the younger ones and the remembrance and honor of his late mother who died during childbirth, Val actually went into Ops and Gynae because of the mother's death during childbirth. He has sought the approval of the Vice Chancellor to institute an endowment fund to the tune of 1 million naira for the best graduating medical students in obstetrics and gynecology, and another 1 million naira to the best master's student graduating from the Institute of Maternal and Child Health in honor of his late father, Mr. Augustine Ugwu. These prize awards, consisting 100,000 naira each, and the certificates signed by the head of Department of Ops and Gynae, as well as the director of IMCH, respectively, will be continually financed by the annual interest from a fixed deposit amount of 2 million naira endowed in perpetuity in the Nigerian Commercial Bank. The operational details of these endowments will soon be provided. Ladies and gentlemen, can you just join me to welcome our 185th inaugural lecturer, Brother Emmanuel, Onyebuchi, Valentine, Ugwu, who is also called a professor. Welcome back.
Professor Solomonyibo Antimela. Professor Sukayemonyibo Antimela. Erudite Professor Solomonyibo. Erudite Professor. I actually know Yibo. Like this, like that. Obonyibo Kobiwe. Like a go di go. Togaria ya no Yibo. That's so. Erudite Professor. Solomon Yibo. Ezibo Professor. I actually know Yibo. Ezibo Professor. I actually know Yibo. Like this, like that. Solomon Yibo.
I welcome you all to the 185th inaugural lecture of the first indigenous university of Nigeria, developed by our founding fathers to restore the dignity of man. This is the 6th inaugural lecture in the Department of Obstetrics and Gynecology, where I belong to. And it's the 2nd inaugural lecture from the class of 2001, which is my own class, the popular OMSA 99 class. It is the first in the history of my alma mater, the one and only one great community secondary school in Bagwan, in Soka. And that school is where legends are born and where men are molded. And it is the first in the history of my hometown, Ibagwani, in Suka local government area. My only regret today is the absence of my dear parents. First, the absence of my father, August Ugwu, who unfortunately is not alive today to witness this very joyous moment. And also that of my dear mother, Mrs. Janet Ugwu, who died while giving birth when she was just 25 years and when I was barely 7 years old. Despite this regret, today remains a very memorable day to me and my family. I thank the Vice Chancellor, Professor Ugwu, who has persistently permitted a seamless and faster appraisal process in the University of Nigeria, and who ensured that my professorial appraisal lasted less than 1 year. I thank you all for accepting my invitation and accommodating me in your very busy schedule today. Why did I specialize in obstetrics and gynecology? I was prompted to specialize in obstetrics and gynecology because of the death of my dear mom, who died while giving birth. And she died due to poor obstetric care from preventable cause. So I chose the specialty to help improve childbirth experience and to ensure that no woman dies during childbirth from any preventable cause. And this I have ensured to the best of my abilities. So the choice of this lecture was first to reflect the purpose of my specializing in ONG, which is because of my mother's avoidable maternal death, and to improve women's childbirth experience during childbirth. Secondly, because I realized very early in my career that women often suffer during labor in developing countries, including Nigeria. I also realized that most of the sufferings of women and most of their discomforts during labor
arose as a result of prolonged labor. Prolonged labor is when labor lasts longer than usual. It causes a lot of problems. I also realized that most of the deaths of women during childbirth arose because of adverse events during the birthing process, and also because of some of the complications that follow childbirth. These are the things I realized very early in my career in obstetrics and gynecology. And bearing all this in mind, I began to generate and test hypotheses that could help me improve women's childbirth experiences and help the whole world protect their perineum and prevent their pelvic floor from harm and consequent postpartum injuries. I hypothesized that any interventions that could reduce the duration of pregnancy or any interventions that could reduce the duration of labor or any interventions that could prevent the development of certain postpartum complications during childbirth, as well as preventing injuries to the pelvic floor and preventing development of pelvic floor injuries, including urinary incontinence, anal incontinence. Any of these interventions will ultimately result in improved women's childbirth experience. Consequently, I tailored majority of my researches and majority of my publications into interventions to achieving these great desired objectives. All of these culminated to the choice of this lecture today, titled The Obstetrician and the Pelvic Floor, Protecting the Floor and Improving Childbirth Experience. This lecture is in 4 parts. The first part of this lecture will give an overview of an obstetrician and the female pelvic floor. The second and third part of this lecture will center on the antepartum and intrapartum measures. When I say antepartum, I mean those things you can do before birth. Intrapartum are those measures you can do during the labor process. So those measures that will help to reduce obstetric injuries to the pelvic floor. And then the fourth part, which will discuss the consequences of injuries to the pelvic floor. In each of these parts, I will highlight the outcome of my study interventions alongside other related studies in literature. And I will conclude this lecture by presenting my research works post-professorial appointment and my current and future research interests and directions. To give an overview of what an obstetrician is, because we need to understand, I don't want to assume that all of us know who an obstetrician is. So an obstetrician is that physician that specializes in the care of women during pregnancy, during childbirth, and also after they had given birth, which we call puerperio. That's what an obstetrician is. An obstetrician is also that specialist who helps in treating medical conditions that are unique to pregnancy, and they can also perform surgeries, or they usually perform surgeries related to labor and delivery. It's also important that we know who a gynecologist is. A gynecologist is a physician that specializes in treating conditions that affect the female reproductive system. And we know that this female reproductive system includes the vulva, that's the outer part of the vagina. It also includes the vagina itself, includes the uterus, which we call the womb, and includes the ovaries. Now, the training of these two specialties, that the training of obstetrics, the training of gynecology training, they usually go together. And that is why a specialist is usually referred to as an obstetrician and a gynecologist. Now that we have all understood who an obstetrician is, the next thing in this lecture is to understand what the perineum and the pelvic floor refer to. The female perineum is that diamond-shaped structure inferior to the pelvic diaphragm, and it is located between the pubic symphysis and coccyx, and between the lower aspect of the thighs. A very important part of the female perineum and the pelvic floor, especially the perineum, is the area called the perineal body. So if you are looking at this pointer, this place is what we refer to as the perineum. This thing you are seeing here is the vaginal opening. This is where babies come out through. And this one you see is the anus. I'm sure we all know what we use the anus for. So in between the vagina and this anum, this small area you see is the perineum. And deeper is where you have the pelvic floor muscles. Now, this is the powerhouse of the woman. This is the engine of every woman. A woman loses her womanhood if anything happens to this perineum. So, and a good obstetrician will guard this perineum very well, because the most consequences of childbirth arise as a result of injury to this perineum and injury to the deeper structures, which we refer to as the pelvic floor. So we can see the muscles of the pelvic floor and the muscles of the perineum. Now, I brought this picture to illustrate further so that we understand what we are talking about. Here is the vagina. You can see the head of a baby coming out. And here is that anus that we are talking about. And in between here is the perineum. And deeper is the pelvic floor. The pelvic floor also acts as a constrictor, as a ring to the vagina, at the inner aspect, and also as a constrictor to the anus. All right, so once there is injury to the pelvic floor deep, once there is injury there during childbirth, then it will result in a lot of complications thereafter. It's also important for us to note that it is this perineum that most of the cuts that we receive during childbirth, all the episiotomy cuts that midwives usually give, are usually here, okay? And deep inside is the pelvic floor. Because I took a lot of pictures for my patients. They accepted. I've retained those pictures over the past 9 to 10 years. But when I communicated with them a few days ago that I'm going to share their pictures and it's going to be streamed online, for a second consent, they said I cannot stream their private parts. And all of them refused the consent for me to stream their private parts. And as such, I didn't have options. So the pictures that you have here are the ones I got approval from the internet. These are the ones I'm showing. So this is just to illustrate the degrees of tears that you can have in the perineum, which can go deeper to affect the pelvic floor most of the times. And this is also to tell you the kind of trouble that our women pass through. This woman, just because of childbirth, look at how the vulva and the perineum has been scattered. You can see that there's no difference. The anus has been torn, all this sphincter here torn. This is the vagina. So that perineum, that pelvic floor, everything has been shattered just because of childbirth. Now this brings us to the second part of this lecture, which will now center on the antepartum measures for protecting this pelvic floor and for minimizing obstetric injuries and improving childbirth experience. Like I said, antepartum measures are those interventions that have undertaken in the past that will help all over the world to protect this pelvic floor from injuries so that women could have a better childbirth experience. Because a woman cannot deliver, and after delivery, she goes home suffering because of trauma to her pelvic floor and her perineum. Most of them, after childbirth, they can't control their flatus. They'll be passing flatus indiscriminately. Some of them will even be passing feces. Some will be passing urine, uncontrollable, and so many other things. We can't talk about the effect of childbirth on the pelvic floor and the perineum. And currently, all over the world, there is a concept that they refer to now as designer's perineum, where women in Europe pay as much as $5,000, $10,000 just to have a surgery to restructure and reconstruct their perineum and pelvic floor after childbirth. So a good obstetrician should ensure not just that a healthy mother and a healthy baby have resulted in the delivery, but you should also ensure that that perineum and pelvic floor are maintained intact and are strong. Perineal trauma during childbirth is a very common experience. Like I've said, that trauma can be as a result of spontaneous tear. It can also be as a result of episiotomy, often given by the midwives. It can occur spontaneously as a result of laceration or intentionally as a result of the episiotomy. Now, in order to reduce the incidence of perineal trauma and injuries and associated postpartum morbidities, Ugwu et al. Designed a randomized control trial in 2018 to determine the effectiveness of antenatal perineal massage in reducing perineal trauma and postpartum morbidities. What did we do here? We randomized eligible women into 2 groups. The group that will receive antenatal perineal massage. What do I mean by that? From 36 weeks of gestation, the women that were grouped into in the intervention group, we taught them how to do the perineal massage themselves. We also taught their husbands and the midwives. So they could do that by themselves. Their husbands could help them to do, or when they come to the clinic, the nurses could also help them. So they did the perineal massage from 36 weeks, 2 to 3 times a week, from 36 weeks to 40, 41 weeks when they delivered. The control group did not have any massage. So what did we find out? We found out that this technique was significantly associated with reduced perineal trauma and reduced pelvic floor trauma. So people who had this technique, most of them didn't have any tear. They didn't have any trauma to the pelvic floor. They didn't have any trauma to the perineum. And they were also less likely to receive episiotomy. So once you do this technique, you will not need to have tear by any midwife during childbirth. And if you do this technique, you are not likely going to have incontinence, whether it is flatus incontinence and whether it is fecal incontinence. You won't deliver, and few days after delivery, you can't control your feces, you can't control your flatus, which happens to many women. I'm sure the women here know what I'm talking about. In view of these findings, we recommended that women should be counseled on the likely benefits of this technique and the information provided to them during antenatal care. So every woman should be offered this technique and encouraged to do it. Also, obstetricians should consider the technique as a routine prenatal care, especially for nulliparous women, especially for women who have not had childbirth, because they are the ones that usually receive this cut. They are the ones that usually have their perineum torn after childbirth. So we recommended over the world that obstetricians should consider offering this technique to the women to reduce this injury to their perineum and the pelvic floor. It is important to state here that this intervention that we carried out in 2018 is currently being widely used in Europe and America for all women who wish to have their perineum intact after childbirth. What is the impact of this study? Because I believe that as scientists, if you do study, you need to evaluate your study and know the impact. If your study is not making any impact, somehow I believe you have wasted some money doing the research. So when I evaluated the impact of this study, I noticed that this technique, like I said, is being widely used everywhere. Going by the references that the citation that he has received, and going by the calls and the emails that I've received from people asking for the technique and asking for the full manuscript. I also observed that this study, within 2018 to now, less than 5 years, has received over 500 citations, just less than 5 years. And this article was rated the best clinical article by the Journal of Obstetrics and Gynecology of Japan in 2021. It is a well-known fact that prolonged labor, otherwise known as post-term pregnancy, here we are talking about labor lasting longer than normal. We know that when labor is prolonged, it's associated with several risks, including instrumental deliveries, pelvic floor injuries, and sexual dysfunction. So no pregnant woman should allow her labor to last longer than necessary. In our effort to reduce the incidence of post-term pregnancies in our environment, Ugwu et al. In 2014 designed a randomized control trial to evaluate the effectiveness of membrane sweeping to prevent post-term pregnancy and improve childbirth experience. We studied 134 post-date pregnant women at the University of Nigeria Teaching Hospital in Enugu, and we observed that sweeping the membrane, as simple as it is, will prevent incidents of post-term pregnancy. Just sweeping women's membranes. A simple technique. Instead of allowing that pregnancy to last longer than necessary, once the woman has reached 40 weeks, you sweep the membranes. We notice that majority of them will go into spontaneous labor and will not need to come for admission for formal induction of labor. We therefore recommended that this technique be considered as a first-line intervention for women with postdatism. Once your pregnancy has passed beyond the date, which we call EDD, even if your obstetrician does not remember, ask him or remind him, please sweep my membrane. Let the obstetrician sweep the membrane because the technique has been shown to reduce the incidence of post-term pregnancy and has also been shown to reduce the need for induction of labor. Because when we bring you to the hospital to induce you, you usually pay much higher. But if you do that technique, I have not seen any obstetrician that will do membrane sweeping for a woman and ask the woman to pay additional money. But once you bring you in for formal induction of labor, you know your money will double. The major impact of this study is that it has contributed data to the systematic review and meta-analysis commissioned by World Health Organization. And this systematic review, which is the highest level of evidence, has recommended that membrane stripping should be offered as the first-line strategy for prevention and management of post-term pregnancy. We know that induction of labor is a common strategy that obstetricians often employ to artificially initiate labor. And it is widely carried out all over the world in cases where continuation of pregnancy is hazardous to the mother or to the baby. But in cases where the cervix is unripe, because you can't start induction of labor if the cervix is not ripe, if the cervix is not favorable. So that's where the problem is. You want to bring out the baby, but you are noting that the cervix is not favorable. You can't start that induction until you make that cervix to be ripe. So what do you do? Now, our trainers in the past, majority of them have already retired, we are using Foley's catheter for this ripening process. And Foley catheter sometimes can stay up to 5 days before you can achieve a ripe cervix. We also know that if you use high-dose misoprostol, which we call 25 microgram and above, that it will ripen the cervix faster than Foley's catheter. But that high dose is associated with hyperstimulation and uterine rupture. So what do we do? The low dose, which is 25 microgram, we know is very, very safe, but may not be as effective as the 50 microgram. So, in view of this, Ugwu et al. In 2013 hypothesized that since low-dose misoprostol of 25 microgram has similar efficacy with Foley catheter, both in effectiveness and risks, we hypothesize that the synchronous use of this Foley catheter and the low-dose misoprostol, just 25 microgram, could hasten the ripening process and will be useful in those clinical situations where CS is often performed due to unfavorable service, especially in preeclampsia and eclampsia. And this led us to design a randomized control trial, which I used for my part 2 dissertation of the National Postgraduate Medical College in 2010. And that randomized control trial assessed the comparative effectiveness of Foley's catheter and synchronous administration of misoprostol. So Foley's catheter and misoprostol used together. We compared the efficacy and the effectiveness and the complications. We compared that with using catheter alone and using low-dose misoprostol alone. What did we find out? We found out that the time to achieve a favorable cervix, that's the time to make the cervix favorable to start your induction of labor, was significantly reduced when you use the Foley catheter and the low-dose misoprostol together, compared to using misoprostol alone or using the Foley catheter alone. What is the impact of this study? This technique is now widely used across the world whenever there is need to expedite vaginal delivery, especially in the face of unripe cervix. And the favorable outcome of this study, no doubt, increased our local confidence in the use of misoprostol for cervical ripening and induction of labor. Prior to this study in 2011, only few obstetricians were using misoprostol for induction of labor. Some had the experience, some were still afraid that using misoprostol will result in rupture of the womb. But following the study, a lot of people had confidence that misoprostol at low dose 25 microgram is not that as hazardous to the woman as had expected before or had thought before. In our further efforts to make labor less stressful to our women, and in our further efforts to improve their childbirth experiences, Ugwu et al. In 2015 explored alternative routes of administration of misoprostol other than the traditional vaginal route, because we usually give that misoprostol vaginally. And we know that some women feel embarrassed when you are putting the misoprostol into their vagina. Some are not comfortable with that. And we now said, can't we try the oral route? Is the oral route effective? And if it's effective, why should you be putting hand in a woman's vagina unnecessarily? Can't you ask her to swallow the misoprostol? So we tested to know whether the oral route is also effective. We observed that both routes castor oil for induction of labor. But in literature, it was a lot of controversy as to whether it's effective and whether it's not effective. And so, Okoro and Ugwu et al. Designed a randomized control trial to investigate the effectiveness of single oral dose of castor oil taken at 40 to 41 weeks for preventing post-term pregnancy. We observed that women who received castor oil had a lower incidence of prolonged pregnancy compared to the women who didn't receive castor oil. And we also observed that women who receive castor oil are less likely to require oxytocin for augmentation in labor. So what does that mean? If your pregnancy has passed beyond date, discuss with obstetricians on the need for you to take castor oil, because that castor oil is very, very effective. It helps a lot in preventing women from carrying their pregnancy beyond the normal time they are supposed to deliver. We therefore recommended that obstetricians should offer women single oral dose of castor oil to prevent prolonged and post-term pregnancy, and to also reduce the need for giving them oxytocin in labor. Still on our efforts to improve childbirth experience, Eleje and Ugwu et al. In 2018 designed a multi-center double randomized control trial to test the efficacy and safety of a novel biomarker called PrimaQuick for pre-induction cervical ripening. We observed that this biomarker is more reliable than our traditional modified Bishop's score in identifying unripe cervix, and that is associated with less need for misoprostol use. In 2022, Eleja and Ugwu et al. In a related intervention compared the efficacy of PrimaQuick and transvaginal ultrasound for pre-induction cervical ripening. We observed that this technique is effective, that this technique is objective, and that the technique is safe, just like the transvaginal ultrasound, but has added the advantage of better prediction of onset and duration of labor. This now brings us to part 3 of this lecture, which discusses the intrapartum interventions for reducing perineal and pelvic trauma. All we have been talking about those interventions, those studies that I have carried out in the past to help reduce injuries to the pelvic floor and make women to have a good childbirth experience. And those interventions we are doing pregnancy. Where we are entering now, we are entering those interventions that are carried out with women while they are in labor to see whether we could reduce injuries to the pelvic floor and to see whether we can improve their childbirth experience. In 2019, Inaugural and Ugwu et al., we hypothesized that intrapartum perineal massage, you see, I had already done that massage, antepartum, that is before labor. Now, and it was effective, and people were using it all over the world. Then in 2019, we said, can we try whether this technique, whether it will work? If you don't do it during pregnancy, suppose the woman couldn't do it pregnancy and she has come to labor, can the nurses do that? Can the midwives do it while the woman is in labor? And whether it will reduce the risk of giving the woman episiotomy, the risk of the woman having tears, the risk of the woman having uncontrollable leakage of urine after childbirth, the risk of women passing flatus uncontrollable, the risk of women passing physis. So, we designed a randomized control study to determine the effectiveness of perineal massage during the second stage of labor in preventing perineal trauma in women who are giving birth for the first time. We observed that the technique significantly reduces the risk of perineal and pelvic floor trauma compared to the traditional hands-on technique. So if you offer women massage when they are in labor, even when they didn't do it antenatally, if the midwives offer them massage when they are in labor, that perineum and pelvic floor will likely remain intact, and they will not have any need for any episiotomy. They will not have any tear during childbirth. We also noted that that technique will reduce the duration of second stage of labor, and it will also reduce the risk of those women having episiotomy, which is the cut that we give to women during childbirth. We also noticed that the risk of postperineal pain, postpartum pain, most women usually come down with pain after delivery. We noted that women who receive this massage are less likely to feel pain after childbirth. And we therefore recommended that this technique should be offered to women during their second stage of labor by the midwives. In our further efforts to improve childbirth experience, Ejikeme and Ugwu et al. In 2020 designed a randomized control trial to investigate the effect of hyoscine bovine, which we popularly call Buscopan. We investigated to know whether this drug has any what is the effectiveness of this drug when you give it to the women while they are in labor. Will it reduce the duration of labor? We found out that this drug shortens the duration of second stage of labor, and hence we recommended that
women, when they are in second stage of labor, towards the end of first stage of labor, that the woman should be offered the drug as it has potential to hasten the delivery process. In 2021, Onyebuchi and Ugwu et al. Noted that delayed cord clamping after delivery has potential to improving neonatal hemoglobin. But the fear all over the world is that if you delay cutting the clamp, the baby has the risk of having polycythemia. And so what do? We designed a randomized control trial to determine the effect of delayed cord clamping against the immediate umbilical cord clamping on hemoglobin and bilirubin concentration of the newborn. And we found out that delayed cord clamping increases the hemoglobin concentration, that of the newborn, increases also their bilirubin concentration without any adverse events. We therefore concluded and recommended that women should be offered delayed cord clamping at birth because it has potential to improving the hemoglobin concentration of the newborn. And this brings us to the fourth part of this lecture, which now discusses the postpartum complications of obstetric injuries to the pelvic floor and the perineum. So if you're unable to do all these measures, antepartum and intrapartum, what are the complications? What are those problems that the women will have if they don't receive all these measures and the pregnancy goes unattended to? In order to appreciate the impact and magnitude of childbirth on pelvic floor, Onyebuchi and Ugwu et al. Undertook a longitudinal study in 2015 to investigate the prevalence and predictors of urinary incontinence and anal incontinence after vaginal delivery among Nigerian women. We observed that the prevalence of these two public health conditions, like urinary incontinence and anal incontinence, we observed that the prevalence of these conditions was very, very high among our women after childbirth. And we recommended that obstetricians should increase their efforts in preventing prolonged labor, which was the most important major risk factor that we identified in the study. Now, it was obvious from our previous study, which I just stated, that the incidence of urinary and anal incontinence was very high among our women. But we noted that in that study that we did not determine whether cesarean section, if women are offered cesarean section, will it reduce their risk of having urinary incontinence and fetal incontinence and fecal incontinence. In order to fill that gap, Onyebuchi and Ugwu et al. Designed a prospective cohort study in 2017 to determine the effect of mode of delivery on incidence of urinary and anal incontinence after childbirth. We found out that elective CS, but not emergency CS, elective one, reduces the risk of urinary incontinence and also reduces the risk of anal incontinence after childbirth. We therefore recommended that those women that are at risk of having urinary and anal incontinence could be offered elective CS in order to reduce those risks. In our further efforts to understand the magnitude of childbirth injuries to pelvic floor, Ugwu and Emmanuel in 2002 designed a prospective cohort study to determine the effect of obstetric anal injuries, which we call OASIS, on the incidence of urinary and anal incontinence after childbirth. This study was my Doctor of Medicine thesis of the National Postgraduate Medical College of Nigeria. We observed that women who suffered OASIS, that's women who suffered either third degree or fourth degree perineal tear during childbirth, are at increased risk of developing these public health issues. Once you suffer third degree and fourth degree perineal tear, the chances that you are going to have that you'll be leaking urine uncontrollably or leaking feces or leaking fluids uncontrollably, the chances are very, very high. And we noted that so many of our women usually have third degree and fourth degree perineal tear without even knowing that they have it. It's only when they come down with incontinence that will begin to run around and find a way to repay it. We therefore recommended that a thorough perineal and pelvic floor assessment by skilled birth attendants should always be done after childbirth. Because what commonly happens is that a woman is in labor, she delivers, Everybody is happy. She has delivered, oh, the mother is fine. The baby is fine. Everybody, even before the woman will come out, they have made calls everywhere to say the woman has delivered. Nobody bothers what happens to her pelvic floor. Nobody bothers what happens to her perineum. That woman could be having 3rd degree or 4th degree perineal tear, which we call oasis. And this study has shown that this oasis has a very high risk of urinary incontinence and a very high risk of anal incontinence. Improving women's experiences during childbirth and during pregnancy cannot be complete without attending to their sexuality. You can't completely improve their childbirth experience if you don't attend to their sexuality during pregnancy and after childbirth. This is because when sexual dysfunction occurs in pregnancy, it could cause marital disharmony. And this marital disharmony can result in psychological distress that can even promote sexual infidelity. Ugwu and Dim et al., therefore, in 2013, designed a prospective longitudinal study to determine the comparative effect of different trimesters of pregnancy on sexual functions of the woman, and also to determine the risk factors of sexual dysfunction in pregnancy. This study is one of my published part 2 works. No, one of my PhD thesis in human reproduction and women health. It's one of the published ones. We observed that sexual dysfunction, as well as prevention of coitus, declined as pregnancy advanced. We recruited the women in the 1st trimester, and we followed them up. Not just till delivery, we followed them till 3 months after delivery, monitoring how their sexual functions are, monitoring whether pregnancy and childbirth will have effect on those public health issues. We observed that 50.7% of women in Enugu have incontinence. No, have sexual dysfunction in pregnancy, meaning that half of the women, half of pregnant women in Enugu have one form of sexual disorder or the other when they are pregnant. A further part of my published PhD thesis, titled Urinary and Anal Incontinence in Pregnancy in a Nigerian Publication, was designed to investigate the comparative effects of different trimesters of pregnancy on urinary incontinence and anal incontinence. We observed that the incidence of these pelvic floor issues are very high during pregnancy, and recommended that obstetricians should always inquire about them and make efforts to address them. Oftentimes, obstetricians don't ask women about their sexual life during pregnancy. We also don't ask them whether they are leaking urine and whether they are leaking feces. And this study has shown that as high as 50% of women, when they are pregnant in Enugu, leak urine uncontrollably. And nobody asks them that when they come for antenatal care, and nobody addresses it. We also went further to investigate the effect of childbirth, especially the mode of delivery, on sexual health of the woman. We decided to know if women are offered cesarean section, will it improve their sexuality after childbirth? So Ugwu et al. In 2020 designed a prospective cohort study to investigate the effect of mode of delivery on sexual functions of partners in Nigeria. This study was my MSc dissertation in 2020. And we observed that the mode of delivery has no overall effect on sexual functions of the woman. So we concluded that women should not be offered CS, because even if you offer them CS, it's not going to improve their childbirth experience. So the idea of, let me have CS so that my sexual life will be intact, does not hold any water. It doesn't. That's what this study showed. Whether you have vaginal birth or you have cesarean section, there is no difference in terms of your sexual life or sexual function after childbirth. We noted that no remarkable improvement can be achieved in women's health and childbirth experiences without upholding women's rights and respectful conduct during maternity care. you must respect women during the antenatal care and during childbirth. This is because, according to White Ribbon Alliance of 2023 on respectful maternity care and universal rights of women, the most important right of every woman on earth is the right to freedom from harm and the right from ill treatment during childbirth. No woman should be harmed unnecessarily during childbirth, and no woman should be ill-treated during childbirth. Therefore, Okafor and Ugwu in 2015 conducted a cross-sectional study to estimate the magnitude of disrespect and abuse during childbirth in Nigeria. Are our women disrespected and abused during childbirth or not? A simple cross-sectional study. What did we find? We published this study in the International Journal of Obstetrics and Gynecology in 2015, and this article, surprisingly, became the best article for the year for the International Journal of Obstetrics and Gynecology. And this article has received over 1,000 citations just in less than 1 decade. So what did we find out? We observed that the prevalence of abuse and disrespect during childbirth in Enugu, Nigeria, is as high as 98%, almost 100%, suggesting that every woman in Enugu, in Nigeria, because whatever happens to Enugu, obviously will happen in other parts of the country. Every woman is abused during childbirth. Every woman. Every woman, no exception. From the time you enter the labor ward until the time you are discharged, you must receive one form of disrespect or abuse. And these abuse range from non-consented services, like interventions like pitocin, augmentation in labor. How many women, the obstetricians or midwives, take their consent before they add the hot drip, before they put the pitocin, which they call hot drip, to them? They don't tell you. They just walk in and feel that the labor is not going very well. Without your consent, they put the hot drip there. How many women receive, or how many women give their consent to health caregivers before we offer them episiotomy? Most times we don't take their consent. We just think it is necessary to give them cord. Fiam! We have given the cord, as if they are animals. These are the things you can't do in advanced country. But that is what is happening, and these are measures of disrespect and abuse during childbirth. Again, we also observe that there are several physical abuses. Some women are slapped, some women are beaten on their laps by midwives in order to get them to cooperate, meaning they are being disrespected and abused just because they have come to give birth. We also notice that a lot of psychological abuses, like shouting on them, raining insults on them. Jesus. These are the kind of abuses that our women receive when they are in labor. Again, some of them are discriminated upon. When a poor woman walks into the labor ward, sometimes, not all the time, they are not given the same treatment like when a rich woman enters. They are segregated. And sometimes when they notice those that have HIV status, hepatitis B status, they discriminate against them. If they are supposed to check the woman every 2 hours, they'll be checking them once in 6 hours, which is an abuse and a disrespect to them. Now, following the publication of this disrespect and abuse in 2015, the Bill and Melinda Gates Foundation commissioned a systematic review and comparative analysis of methods in order to aggregate and present lessons learned from published studies that quantified the prevalence of abuse and disrespect all over the world. I was invited to collaborate with renowned researchers across the world, including from Harvard Medical School, to co-author another second award-winning paper, which was published in Journal of Reproductive Health in 2017. In this study, Sando and Ugwu et al. observed that there is lack of standardized definition and instruments and lack of study methods in published studies. And we therefore recommended for caution in generalization and for caution in comparison of results. Ladies and gentlemen, I did not stop research after my appointment as professor in 2020. Rather, I intensified my efforts in research and publication. I did not stop. Thus, between 2020, when I was assessed for professorial appointment or promotion, and now I have co-authored a total of 37 publications between 2020 and 2023. Out of these 37 publications, 25 were published in journals with Thomson Reuters impact factor. But I will present only a few. In this lecture because of time. In 2022, we identified that we could improve women's childbirth experience by investigating an intervention that could improve their hemoglobin status during pregnancy and childbirth. And therefore, Eleje and Ugwu et al. Embarked on a phase 2 double randomized controlled trial to investigate the efficacy and safety of Mojega remedy in combination with conventional iron therapy for correcting anemia in obstetric population. We observed that this Mojega remedy increases hematocrit values of the neonate without any adverse events. In 2023, Eleje and Ugwu et al. Conducted a randomized clinical trial on the effectiveness of pre-matric biomarkers for pre-induction cervical assessment. We observed that this technique is more accurate and more reliable than transvaginal ultrasound. Also in 2023, Eleje and Ugwu et al. Conducted a TEDFund-sponsored systematic review and meta-analysis on triplet infections in Nigeria. We observed that the prevalence of triplet infection is 0.03% and that it is more common among HIV-positive women. In 2023, I co-authored a chapter in a TEDFund-sponsored textbook on fundamentals of systematic review and meta-analysis for postgraduate education on systematic review and meta-analysis. I will now move forward to highlight a few of my Cochrane collaborations and a few of my systematic reviews and meta-analysis since after my professorial elevation in 2020. In 2020, Eleje and Ugwu et al. Conducted a Cochrane systematic review and meta-analysis on risk-reducing bilateral sapping oophorectomy in women with BRCA1 and BRCA2 gene mutation. We demonstrated that this intervention, this surgery, increases the overall survival of the women and reduces their mortality from ovarian cancer and from breast cancer. So women with BRCA1 and BRCA2 gene mutations have reduced risk of death if they are offered bilateral sapping oophorectomy. In 2021, Ugwu et al. Published a Cochrane systematic review and meta-analysis protocol titled Antivirals for Prevention of Hepatitis B virus, Mother-to-Child Transmission in Human Immunodeficiency Virus Positive Pregnant Women co-infected with Hepatitis B virus. And in 2023, Ugwu et al. Published a full Cochrane systematic review and meta-analysis on antivirals for prevention of Hepatitis B virus, mother-to-child transmission. We demonstrated that tenofovir-based antiviral combination regimen results in higher risk of serious adverse events to the neonates. My future research works. Where do I go from here? What are my future plans? What are my future research directions? I tend to investigate further some homegrown interventions for protecting the pelvic floor and treating various types of women incontinence, pelvic floor prolapse, sexual dysfunction. I also intend to seek grants to set up a pelvic floor facility in UNTH for modern treatment of pelvic floor disorders arising from childbirth. This facility will be positioned to attract grants for aesthetic surgeries. And in this facility, we'll be redesigning surgeries for women who have injuries, who had injuries to their pelvic floor and who had injuries to their perineum. We believe that with the grants that we will seek and we hope to get, that we'll be able to be doing these aesthetic surgeries in UNTH. In conclusion, the Vice Chancellor and the distinguished audience, I will conclude this lecture by stating that a good obstetrician ensures not just successful pregnancy and delivery of a neonate, but ensures a mother with minimal risks to her perineum and pelvic floor. That's what a good obstetrician should do. And that achieving these expectations will ultimately result in improved women's childbirth experience and reduced postpartum morbidities. The primary part of this 185th inaugural lecture presented a concise overview of the female pelvic floor vis-a-vis their structures and functions. Thereafter, I proceeded to the first, second, and third part of this lecture, which centered respectively on the antepartum and intrapartum measures with potentials to reducing obstetric injuries to the pelvic floor and minimizing postpartum morbidities. In each of these last parts, I discussed the outcomes of my study interventions alongside the outcomes of other related studies in literature that protected the pelvic floor and reduced the risk of postpartum morbidities and improved childbirth experience. I then discussed the fourth and the third part of this lecture, which presented a concise description of my research output since promotion as a professor in 2020. And I've ended this lecture by my proposed future research goals and direction. It's now for acknowledgement, ladies and gentlemen. First, I want to thank the Almighty God who loves me so much beyond imagination and who has showered me with constant blessings, constant uncommon blessings. I wish to appreciate my sweet baby, my angel, my queen, the wife and a special mother to me, the queen of Aguleze Chukwu Kingdom, Dr. Angela Ugwu. I cannot appreciate you enough. The Holy Book corroborates my thoughts that he who finds a wife finds a good thing and obtains favor from God. Thank you so much for accommodating me, for accepting me, and tolerating all my exuberances. Then, our four lovely children. Can you stand up for recognition, please? Can you stand up? Starting from Val Ugwu Jr., Dumebi, Chisom, and Kenena. Four of you are God's gift to us, and we love and appreciate you so much. May God continue to bless you. Can you sit down, please? Sit down, sit down, sit down. My late father, popularly known as Nkonye Metalo, a renowned police officer who never intimidated anyone unjustly throughout his career. He stood for the truth and upheld the truth throughout his career. And upon his death, I adopted the title Ikpe Malo Ezoku, which I am popularly called in my parish, St. John the Beloved Catholic Parish. That's what I'm called. And I adopted this name in order to uphold his great virtues. And then my mother, Mrs. Janet Ugwu, who died while giving birth to her third child at the age of 25 years, when I was just 7 years. May their gentle souls rest in peace. Like the Dean has said, in remembrance of these great individuals who brought me to this universe, Mrs. Janet Ugwu, who died during childbirth, I have obtained the approval of the Vice Chancellor of this great university to institute an endowment fund for the best graduating student in OBGYN, that's obstetrics and gynecology, endowment fund of 1 million, and another endowment fund of 1 million for the best graduating student, best master's degree students in the Institute of Maternal and Child Health. These prize awards, which will consist of 100,000 naira each for the best student in either ONG, and also the best student in Institute of Maternal and Child, will be financed by an annual interest from a fixed deposit of 2 million naira endowed in perpetuity in a commercial bank. Like the Dean has said during the citation, the operational details will be provided once the endowment is done. Then my stepmother, Mrs. Dorothy Ugwu. Can you please stand up, please? My stepmother, Mrs. Dorothy Ugwu. She is here today. She's a very virtuous woman, a woman sent by God to comfort us and relieve us from the burden of the death of my mother. She took me as her biological son and labored tirelessly to ensure that I had a successful medical education. It wasn't easy. It wasn't easy. My father, as a policeman, couldn't have done that, but this woman labored to ensure that I completed my medical education without any problems. I thank God that has kept you alive to reap the fruits of your efforts and sacrifices. Thank you very much. You can stay, you can sit down. Then my sisters that are here present, so many of them, Choma, Anichebe, Nkechi Olubeze, and my brothers, and Chizoba Ezema. Then my brothers, Nabike and Ugwu Chibuzo. May God continue to bless you. My father-in-law is here. Chief Sir Fabian Ezenwambachile, Deacon Ebube 1 of 50 Aguleze Chukwu, Agwata Local Government, Anambra State. A retired principal, a former president of Aguleze Chukwu Development Union, a renowned catechist, and a passionate counselor. In my next word, I would want to remain your son-in-law. And my mother-in-law, Lady Josephine Chinyere Ezenwambachile. Can you please stand up? A retired principal and a great teacher. The best mother-in-law in the whole world. You have always treated me specially and loved me beyond imaginations. I can't thank you enough for what you have done for me. And I can't thank two of you enough for raising your third daughter, Ogechukwu Ugwu, who is a gift to me and my family. Thank you very much. I also appreciate my brothers-in-law and my sisters-in-law. I can't call your names here because of time. I also want to appreciate my uncles, starting from the eldest. Luckily, my uncles. My father's eldest brother is now the Onyishi of my village. Pa Obeta Ugwu, who is the Onyishi, the oldest man in my village. I also wish to appreciate my another uncle, the second uncle, the Royal Highness Igwe Gilbert, the owner of Ibagwani, the entire town. I don't know why he has some. Thank you very much for coming. I also appreciate my other uncles, Barrister Uche Nobu, the MD, UC Network. He's here present. Barrister, I greet. Thank you so much for coming. I also appreciate Chief Collins Obu, Executive Director Operations, Northwest Petroleum and Gas Limited. And also a host of so many others that I can't call their names here because of time. And I also appreciate my cousins, Dr. Emmanuel Ugoke Boidi, a consultant psychiatrist and addiction specialist in Canada. Dr. Ejiofor Omeje, Emmanuel Omeje. He's a lecturer in UNN and he's the CEO of Meeting Points Luxurious Limited. He's also the CEO of Omeje Songhai Integrated Farms. I also appreciate Barrister Onyinye Ifeanyi Idika, solicitor at Greenfield Chambers, and a host of many others that I can't mention their names. I also wish to appreciate all the teachers from my primary school, through secondary school, and through my medical school, but most especially Dr. Anthony Ugwu, who deserves a very special mention. Dr. Ugwu saw the potentials in me as far back as when I was in community secondary school in Bagwan, and encouraged me to study hard, that I have the potentials to read anything I want to read. And even in that school with limited teachers, he's like a man who saw tomorrow. And I believed him and applied for medicine, and here I am, giving the 185th inaugural lecture of this great university. I'm also indebted to the teachers, to my teachers in both preclinical and clinical classes of the medical school, especially Professor Bickley, who taught us anatomy and embryology like no one else. He could draw anything. I also appreciate Professor Jim, who interpreted ECG with us, with ease for us then. I appreciate all the consultants in obstetrics and gynecology in UNTH during my residency years. The collective efforts produced the specialist in me. However, I must especially appreciate Professor Nwaya, the former provost of College of Medicine, who was quick to identify me immediately I started residency training in 2005. He guided me to design and publish a paper within first few weeks of commencement of my residency training. Prof, I thank you so much. He recommended me initially as managing editor of our great journal and later appointed me as the editor-in-chief of the great International Journal of Medicine and Health Development of the University. I will. He also recommended me for appointment as section editor of the Nigerian Journal of Clinical Practice, the very only few Nigerian medical journal with Tom Siruta impact factor. I also acknowledge and thank Professor S.N.O.B., who was a father to me during my residence training program, and who has continued as a father to me. He guided me clinically and academically, and I have co-authored several Part 2 dissertations with him. Thank you, Prof. I'm very grateful. I must thank Professor Cyril Dim. Professor Cyril Dim is my foremost mentor, a supervisor, and a trainer till today. I observed his great research skills early and very quickly in my career, and I applied myself with him. And I adopted the water pouring principle of Elijah and Elisha in the Bible, where Elisha served Elijah with humility and forthrightness, and Elijah was rewarded with the ability to perform similar miracles as what? As Elijah. So Elijah was able to perform similar miracles like Elijah because he served Elijah with humility and forthrightness. Today, Professor Dim and I have similar style of writing that is often indistinguishable between two of us. He supervised my master's dissertation, and he has also supervised my PhD thesis of University of Nigeria. I also want to thank Professor Obiomo Bikeze. Professor Obiomo Keze is a great mentor and a father to me. He appointed me as chief resident when he was the head of department, and later recommended me for appointment as lecturer and consultant immediately I completed my residency training. I also appreciate Professor Hyacinth Ona, who supervised my national Part 2 dissertation. I most sincerely appreciate Professor Benjamin Ozumba, the immediate past Vice Chancellor of this great university. He guided me deeply in research writing and later co-opted me into his research team. And we have both co-supervised several postgraduate dissertations and several theses. I also thank Professor Hyginus Ezegui, sorry about that, cortico-oral dissociation. Professor Zegui is the current provost of College of Medicine. He has continued to guide me clinically and academically, and a host of other members of OBGYN department. I can't thank you enough. I also thank Professor Ngubere, who recommended my appointment as lecturer in this university. And I also thank in a most special way Professor Ernest Onwasigwe, who is a special father to me and a valued counselor to me. Each time I have any issues, I run to him, and he takes me as his beloved son. Thank you, Prof. I'm very grateful. I am very highly indebted to the Chief Medical Director of this hospital, Professor Onodugo, my Oga at the top, the man I owe everything. He identified me very early and brought me closer to work with him, and later appointed me as his deputy, as CMAC, and as Director of Clinical Services of this great teaching hospital. Thank you so much, sir. Thank you so much. I also thank other top management staff of the hospital, including the Director of Administration and Director of Finance, heads of department, heads of units, principals, and coordinators of different schools. And I thank my great classmates, the phenomenal class, for all the contributions they have made for this inaugural lecture. I also thank members of the St. John the Blood Parish. I thank all of them. I can't count the names. I thank the parish priest. I thank the vice chairman of the Parish Pastoral Council, His Royal Majesty, Dr. Pascal Chike Onodugo. I thank, in a very special way, the Emeritus Vice Chairman of the Parish Pastoral Council and former Honorable Commissioner of Health here present, Chief Engineer Greg Unaji, my very good friend and a respected brother from another mother. Thank you so much. I thank you. Thank you for coming. Thank you so much, sir. I also thank members of the Ibagwani community, including the parish priest, members of the Ibagwani Town Union Enugu branch that are here present, and members of the Ibagwani Elite Club. Most of them came from Lagos to make sure they attend this program. I finally wish to thank my inaugural lecture planning committee, a special breed of professionals, ably led by my very good friend and classmate and roommate, Dr. Sir Peter Ekwuemelopi, and the secretary of the committee, Dr. Sir G.O.T. Onya. The support and sacrifices of these great men were unprecedented. My thanks and God bless. I also thank Professor Dries Dim and Professor Tessie and Mr. Ife Chukwuezani for providing this lecture. Finally, I once again thank the 15th Vice Chancellor of this great university, the University of Nigeria, Professor Charles Igwe, for the opportunity given to me to present this great lecture. And I also thank you all, my audience, for attending and for listening to me and celebrating with me this very great day. May the good Lord lead you safely to our various destinations. Thank you so much, and God bless you all. Thank you so much.
Swallow you go, Anti-Mela. Don't be silly of what you call me, Anti-Mela. Don't be welcome, Catacomb, Anti-Mela. Erudite professor, swallow you go. Erudite professor, I see you swallow me. From pillar to post, up to football, up to you.
Thank you. That was an energetic one. Well, I know a good inaugural lecture when I see one, and this is high up there, high up there. Please let's give the 185th inaugural lecturer another applause. As you could imagine, while he was speaking, more than a few special guests entered the hall. For want of time, we're not able to recognize all these gentlemen and ladies. So please, a very warm welcome to you all. But as you would expect, a very distinguished guest, a very special member of this community, the 14th Vice Chancellor of the University of Nigeria, Professor Benjamin Chukwuma Uzumba entered the hall. Please, let's welcome him warmly. And let's welcome his dear wife too, pharmacist Chinelo Uzumba. Please, an applause. I also understand that we have another special guest who's come all the way from the Federal Capital Territory, an honorable member, the House of Representatives, and his Right Honorable Chidi Obeta, representing Iweze South Federal Constituency. Please, an applause and welcome him. Please, a wave of hand if you're in the House. Oh, thank you. At this point, may I invite the chairman to make some presentations on behalf of the university and to please also give his closing remarks, or his post-lecture comments, as we call it.
Ladies and gentlemen, this is a powerful and fantastic inaugural lecture. Can we give a clap to it? From the beginning, I told you that we know what our own very Val Ugwu can do, and he did not disappoint us. I am sure all of us have been thrilled for the past 1 hour, and he has delivered a powerful inaugural lecture, and University of Nigeria is proud of you. It is not easy to develop techniques, to develop strategies that will be adopted by different parts of the world that are in use. He did it. Ladies and gentlemen, let's give it up to Professor Val Ugwu. He has promoted the feasibility of University of Nigeria, and the management, the Vice Chancellor, and the management of the university is proud of you. And everybody here is proud of you. And I want to thank you for this, giving us a very wonderful inaugural lecture. On behalf of the Vice Chancellor, and management of the university, we are presenting you this certificate of presentation titled presented to be known that Professor Emmanuel O.V. Ugwu of the Department of Obstetrics and Gynecology delivered the 185th inaugural lecture of the University of Nigeria. Congratulations. We're also presenting you a plaque in commemoration of your wonderful inaugural lecture. Congratulations. Now, we're also giving you about 50 copies of your inaugural lecture to give to your friends, family members, and those who wish to. 50 copies. Yeah, congratulations. Ladies and gentlemen, I want to especially appreciate the presence of the 14th Vice Chancellor, the immediate Vice Chancellor of the University of Nigeria, Professor B.C. Ozumba, and his amiable wife. I also want to thank all of you for finding time out of your busy schedule to attend this lecture. I am sure you've not been disappointed. All that you've sacrificed to be here is worth it. This lecture is a wonderful one, is a unique one, and we've seen that Professor Ugwu is a prolific and renowned academic, and He's also a scholar of repute, and is one of those that the university will always be proud of. Ladies and gentlemen, we thank Professor Ugwu for giving this wonderful lecture. And I also thank all of you, especially colleagues from the college, for giving your usual support to one of your own. God bless all of you. Thank you and remain blessed.
Thank you, Chairman. Everyone feels happy about what is happening here today, and we're all sharing the pride, but there's somebody who stands out of the pack, the level of pride he feels today. So my pleasure to invite the 14th Vice Chancellor of the University of Nigeria, Professor B.C. Ozumba, to say a word or two. Thank you, sir.
The Chairman of the occasion, the Vice Chancellor of the University of Nigeria, highly distinguished members of the high table, our highly esteemed guests, the inaugural lecturer and his amiable wife and family, my colleagues in academia, esteemed professors, consultants, colleagues in the Department of Obstetrics and Gynecology, our friends and well-wishers. You can see the smiles beaming on my face. I don't consider myself a regular member of the academic environment of the university, but I must have to be here today. So many things have been said about Professor Ugwu, but I'm here. He says his parents are no longer alive, but I'm here, like his father and his mother, because I watched his growth and his specialty of obstetrics and gynecology, apart from being a student under me. And what we have seen here today is phenomenal. We have watched a young man grow from his undergraduate students to resident, obstetrician and gynecologist, clinician, and toward globally. You can see that at every point of his career, he has stood out. The good thing is that this shows what we are able to do in this university, from ordinary to extraordinary. It's not easy to be listed in the academic environments where he has been, involved in global studies, Cochrane studies, and so on. And I'm happy to see the fruits of my, what I would say, exercises in this university. Because when I look back at the College of Medicine, we have more than 6 research centers. Maternal and fetal medicine, community medicine, oncology, so and so on. And he has tested them all and come out excellently, getting PhDs and so on from that. You can see why I'm very fulfilled. I didn't know he had done that. No wonder why University of Nigeria continues to tower. And when I look around, the greatest thing that makes a man happy, like John F. Kennedy says in his family, he didn't go into the family business. He found that going in to make human beings was better. When I look around and see what we have done, on my far right here, we see somebody like Professor Ugwu. See what he's doing in the University of Nigeria, what he is doing with research, director of research. So when I look back anywhere, I'm happy. Those things we set up, he has done them very well, taking them to very top heights. University of Nigeria, when I was there, was able to enter the Times Higher Education, one of the first universities in the country. And that is where you have things like Harvard. It shows what we can do. So I'm particularly happy at what I have seen today, and I'm sure he's just starting, as he has said. What he is doing in research, he's just starting. MD, PhD, and so on. He'll take the university. What determines the university is research. That's what I said, that at the end of my tenure, I set up more than 15 research centers at the University of Nigeria. At least 4 of them are international centers. And you know what that means? When they blossom finally, University of Nigeria will not come second in any ranking in Africa. Because it is the research centers that produce research, top quality. Obin, I think you went with me to Egypt. Oh no, at the end of the tenure, I had to travel. I showed them those people who do rankings and so on. They took us the whole thing. I wanted to hand over to the university to see how these things are done. Don't worry when you see Covenant coming tops every year. The vice chancellor of Covenant had to, immediately we finished the meeting, had to travel with the people doing the ranking. You see, there's a lot of things involved in the ranking. I started ranking here with Chris Bolu, the man who started our computer things, and then he took it to Covenant and continued. So, without making a long speech, I just wanted to unbundle my heart that I feel very fulfilled today. Thank you, and God bless you.
Thank you very much, sir. The chairman has approved that that a club that is so dear to the heart of the inaugural lecturer makes a presentation. It's the OTZ Club, UNTH, Operation 000 Club, the University of Nigeria Teaching Hospital would want to make a presentation to the 185th inaugural lecturer. They have 1 minute to do that.
Special greetings to everyone. Standing on the existing protocol, the inaugural lecturer, I, Ojoka Fosheta, Chief Nursing Officer, and
Victor Pencil.
Victor Pencil. We are here on behalf of our heads, Deputy Director of Nursing, Ugwu Antonia, and Professor Ugwu. They say we should come and present this, your portrait, to you. Because you have been identifying with us. Every year when we are doing our motivation party, you identify with us publicly. We say congratulations. We have to identify with you publicly today. Congratulations, and your beautiful wife. Congratulations, ma. Keep holding him tight, all right? Thank you.
I'm grateful. Thank you so much. Thank you. I can't thank you enough. Extend my gratitude to your boss. Thank you so much, and everyone. Thank you.
God bless you and everyone.
Thank you very much. So can I make the following announcements, please? The next inaugural lecture, the 186th inaugural lecture of the University of Nigeria, will be presented by Professor Felix Nzube Chukwuneke. And Professor Chukwuneke is of the College of Medicine. Please, an applause. I thought that would attract an applause. And I know he's in the house, and his lecture will be on oral and maxillofacial surgical surgery in a developing economy, the making of a surgeon. And so on August the 24th, 2023, which is precisely in 2 weeks' time, we'll be back at the moot court to listen to, I believe, another scintillating lecture from the College of Medicine. Then the 185th inaugural lecturer has requested that we follow this order for refreshment after the lecture. First, the lions and lionesses, the students of the university, will stay back here at the moot court and be served lunch. Then all those sitting on the high table, I understand, and then the Igwes that have come from various places will proceed to CIMAC Hall to be served lunch. That is right across the lawn there. So members of the high table and Igwes, please proceed to the building across the lawn to be served lunch. And the rest of the audience here, the rest of us, will go to the admin building. That is the main hall right at the entrance to the university to be served lunch. So you see the canopy out there. So that's it. Lions and lionesses, you stay back here and get served lunch. Members of the table across the lawn, and the rest of the guests, please make your way to the main hall, and there you'll be served lunch. And vote of thanks, that's the bit that I like so very much, and today there are so many people to thank. I will always start by thanking the Vice Chancellor who who bankrolls the activities of my committee. The inaugurals are becoming increasingly expensive, but he never bats an eyelid when it comes to approving our budget. And so the representative of the chairman, please remember to thank the Vice Chancellor for what he's continued to do. And let me also thank the chairman of today's lecture, Deputy Vice Chancellor Inaugural Campus, for standing in and doing a brilliant job of it. And all the other distinguished members of the university community, the 14 Vice Chancellor, members of the Governing Council, past inaugural lecturers, thanks for coming in your numbers. The provost, the deans of the faculty, please, thank you so very much for coming. Your presence gives this event the power that it truly, the energy that it truly deserves. And what would I say? Today we had so many people from out of town. I've never seen this hall this full. And there is a message here today. The energy in this hall is magical. And I know to some extent it's the lecturer that has pulled you together. But I'm so grateful that you could all come in these numbers. And you know those gowns I keep talking about? I saw some new ones today. So distinguished professors from the College of Medicine and even non-professors from the College of Medicine, thank you so very much for coming in these numbers to make this a rich inaugural lecture. I liked the procession. It was about one of the longest that we've seen. Please be back here in 2 weeks. Let's have another full hall if it's possible. Let me also thank members of his family and his community for showing up. I saw a few of them stand up to get recognized. Many more didn't get recognized, but thank you so very much. You sure know your man, your brother is in very safe hands at the University of Nigeria. He's protected by the Deputy Vice Chancellor, his provost, his dean. He couldn't ask for a lot more from this university on a day like this. And the great lions and lionesses, thanks also. It's unfortunate some of you couldn't even get a seat, but it's fine. We're going to hand over this tradition to you. We're going to pass it on and make sure that you keep it alive when we're long gone. The technical team, you were on top of your game today. The Zoom connection, perfect. I didn't get any complaints, so thank you so very much for doing it right. Music department, you guys are very partial. I've never heard the University of Nigeria song sound so good. It sounded richer, and I couldn't help but sing along. So thank you so very much for whatever you've contributed to make this a magnificent inaugural lecture. Thank you so very much, everybody. My team, you guys were here right on time today. Madam, you know what I think about you. I've always said I'm lucky to have the best secretary at the University of Nigeria, and I think I do. I do have the best secretary. She makes me just look as good. Please appreciate Mrs. Sadiq. She does an amazing job. If you have a secretary like her, you can afford to sleep with both eyes closed. Thank you so much. And she asks for very little in return. Thank you so very much, madam. At this point, the chairman, with your permission, may I invite Emeritus Professor Venerable Ernest Onwasigwe to say the closing prayer.
May we all rise. Gracious Father, we thank you for this time that we have spent with one another and with you. We thank you, gracious Lord, for your grace and for the celebration. As we go, gracious Lord, may we go with your heavenly benediction. For we have prayed in the name of the Father, and of the Son, and of the Holy Spirit.
Thank you, and while we're standing, can we take the second stanza of the national anthem? Right after that, I will appeal that we stay standing so that the Vice Chancellor would leave. Thank you very much.
Strong
Thank you. Please, while you're standing, the Vice Chancellor would leave, and thereafter, thank you so very much, and have a good afternoon. Thank you.
Please, let's be where we are while they recess the hall, please. We plead with you. No movements. We beg you. Thank you very much for making the 185th inaugural lecture a wonderful one and a huge success. We appreciate you for adding color to today's event. God bless you as you return back to your respective destination. We wish you journey mercy. Thank you also to my amiable team, the Public Relations Unit. God bless you. Thank you too for helping us make today's event a success. Thank you all. Please allow the members of the high table to recess the hall before we come out. Thank you. Thank you. Thank you. And to our distinguished guests, we appreciate you. Thank you all. God bless you.
I will never forget my home. Oh, my home. Oh, my home. Oh, my home. When shall I see my home? When shall I see my native land? I will never forget my home. I will never forget my home. Oh, my home. Oh, my home. When shall I
Students, can you hear me? Please wait behind for your lunch here. Students, please wait behind for your lunch here. You're going to get your lunch here, so please wait behind. Thank you. Forever.
forevermore, forevermore. Take glory, Father, take glory, Son, take glory, Holy Ghost, now and forevermore. Take glory, Father, take glory, Son, take glory, Holy Ghost, now forevermore, forevermore. Take glory, Father, take glory, Son, take glory, Holy Ghost, now and forevermore. Aha. Forevermore, forevermore. I have a God who never fails. I have a Father who never fails. I have a Father who never fails. Who never fails. Who never fails. Forevermore. I have a God who never fails. Yes. I have a God, I say, who never fails. I have a God who never fails. He never fails, I say. He never fails. Forevermore. Onye meme ma baba mi o. He never fails. Onye rato palati bi eke baba. He never fails. I have a God, money, who never fails. I say, who never fails. Who never fails, money. Forevermore. Oh, shame. Oh, shame. Oh, shame.